Hello, welcome to Module 3 of the Navigating the Changes from DSM-4 to DSM-5. This course is designed to let you work at your own pace and includes 5 modules, each lasting about 30 minutes, including a post-test. At the end of each module, there is a post-test which you will be asked to complete. And please note that if you exit a module before completing, there will be no means to return to the point where you left off, so you will need to repeat the entire module. So please just try to complete each module in a single setting to avoid having to repeat the information. All 5 modules and post-tests need to be completed in order to receive the completion of this course. So in this section, I will be covering the changes to what was previously referred to as mood disorders. So the very first thing that we see that is significantly different is that bipolar disorders are removed from the mood disorders category. They're separated out from depression because enough research has been done to show that bipolar disorders, particularly the manic episodes, are more closely related to schizophrenia than to depression. And so that's why the chapter was split into 2. I will go over the changes to mania and bipolar diagnoses, and then we'll go into depressive disorders. Both bipolar disorders and depressive disorders have the same specifiers, and those will be discussed after the depressive episodes. When we look at the bipolar and related disorders category, we're looking at bipolar disorder 1, bipolar disorder 2, and cyclothymic disorder. There have been some changes, as well as to the substance-induced, unspecified, other specified bipolar disorders, and those that we have with every category. So one of the major changes that has happened is a couple of things. Well, actually, there's 2 major changes. One is that a person can no longer be diagnosed with bipolar 1 disorder without having had a current or history of a manic episode. Mixed episodes no longer qualify for core diagnostic practice. Although if mixed features are present, you can add that as a specifier. This was done to help tighten up the diagnostic process, as it was shown that bipolar disorder was significantly overdiagnosed. So not only can the person must have a history or present manic episode, but in addition, when we look at the manic episode, not only do we have to focus on the mood change, but there also must be a change in energy level or a significant increase in goal-directed behavior lasting at least a week. Perhaps for me, this is the most significant change, the requirement that there must both be a mood behavior, mood change, as well as the change in energy or goal-directed behavior. Really, in my experience looking at people who have been misdiagnosed, that is one of the areas that is frequently overlooked. They have the mood component, but they do not have the energy level. So the DSM-5 states that they must have both in order, lasting at least a week, and that lead to changes in behavior that is related to the mood. So it really tightens up the language around diagnosing a manic episode. The same symptoms and the same text revisions have been made for the hypomanic episode, except it's just less intense or shorter duration. They do indicate that there may be little to no visible impairment. However, they do note that the person is much more likely to develop a manic episode at a later time or an anxiety disorder. So the text, one of the final things that they do note in the manic episode is that all of the symptoms must be related to the mood alteration and not be part of a personality disorder or related to anxiety symptoms. While this has been part of our diagnostic process for a long time, it was not carefully labeled in the DSM-4, and so they have made that change in the DSM-5. We will look at that is pretty much the only change when it comes to bipolar disorders, and we will be going over specifiers in a little bit. So now we're going to take a look at depressive disorders. There are several depressive disorders a couple that have been added and one that has had significant changes. The first one, and we will go over in more detail, is disruptive mood dysregulation disorder. And that is the one, if you heard that we were now going to be diagnosing temper tantrums, that's pretty much what they're talking about. And I will go over and clarify that in a moment. The couple that have just had some minor changes are persistent depressive disorder. That now combines dysthymic disorder and chronic major depressive disorder. So the symptoms must be present for 2 years, consisting of depressed mood, not irritable, and presence of 2 or more of the following: appetite disturbance, insomnia or hypersomnia, low energy or fatigue, low self-esteem, poor concentration, and feelings of hopelessness. There are specifiers that allow you to note if the presentation is purely dysthymic or if there are persistent or intermittent major depressive episodes. They found that there was very little clinical utility in identifying the differences between chronic major depressive disorder and dysthymia. So they combined them under the persistent depressive disorder diagnosis. So premenstrual dysphoric disorder made it into the DSM, but somehow testosterone and pulse control disorder didn't make it in. Sorry, I can't help but be a little biased about this one, even though I know that a small subset of women do experience these symptoms. And basically, the whole reason it made it into the DSM-5 is that there is a specific pharmacological regimen in order to assist these women. So what happens is that the individual basically meets criteria for major depressive disorder or generalized anxiety disorder for only the week prior to menses, with remittance occurring within a couple of days following onset of menses. And so the treatment that has been developed is basically from the research I read, is that they are given 1 week of an antidepressant per month, and that has been shown to be helpful in symptom remittance. So that is something, it's a relatively small subset of women that do experience those symptoms, but it was included because there has been treatment that has been shown effective. Okay, major depressive disorder. So again, really everything has stayed the same. We have the combination of at least 5 symptoms during the same 2-week or longer period that's different from their normal mood. The symptoms must be related to their mood. The only change that really has occurred in major depressive episodes is the removal of the bereavement exclusion. This, again, was a big source of controversy, and one of the things that people did not take the time to really understand was that the removal of the bereavement exclusion does not mean that someone who is experiencing bereavement should be given a diagnosis of major depressive disorder. The reason the exclusion was removed was that individuals who either had an existing major depressive disorder or who may have had an onset of a depressive disorder during that period of bereavement were struggling to receive treatment due to the bereavement exclusion. So they simply removed that exclusion to allow for individuals who do present with symptoms of a major depressive disorder to receive treatment. So one of the things that the text does a good job of is noting that there are significant differences between bereavement and major depressive disorders. And so they also wanted to change the bereavement exclusion because there wasn't really a whole lot of research that bereavement existed only in that very short time frame. Bereavement can last for several months and in cases sometimes years. And due to that, it just was not found to have real clinical utility, and it was removed. We're going to look here at disruptive mood dysregulation disorder. So this is the temper tantrum one. And really it is also designed to help avoid the overdiagnosis of bipolar disorder in children. Now, the reason why people kind of freaked out about this was that the text itself says recurrent behavioral or verbal or behavioral temper outbursts that are grossly out of proportion to the situation. But when you look at all of the exclusions, it really is very hard to diagnose in someone who does not have significant impairments. This is not going to be a diagnosis given to someone who has just simple behavioral problems. First off, the outbursts have to occur at least 3 times a week for the past 12 months. You cannot diagnose anyone under the developmental age of 6. You cannot diagnose anyone over the age of 18. And what is the most substantial diagnostic feature is not the outbursts themselves, but the mood symptoms that persist in between the outbursts. So what they found was individuals, the children that had this diagnosis, they had a chronic irritable mood, but no mania. So these children were being diagnosed with bipolar disorder, but bipolar disorder is episodic, not chronic, and so these children were not really benefiting from traditional bipolar disorder treatment. They also followed a group of these children who have this presentation into adulthood, and they found that these children were much more likely to develop either major depressive disorder or an anxiety disorder rather than bipolar disorder in adulthood. So what they're seeing as the mood symptoms are really, from my experience doing diagnosing and reading the text, it's much more like an irritable depression that is persistent with superimposed temper outbursts that occur on a fairly regular basis and that are not developmentally appropriate. So unlike someone with, say, intermittent explosive disorder, there is no returning back to a normal mood for these children after an outburst. They go back to that irritable, depressed mood. So it is a chronic condition, and the outbursts are simply one part of the diagnostic picture. So when we look at the differential, we are looking at a differentiating between bipolar disorder, and one of the main factors is there with individuals who have disruptive mood dysregulation disorder, they're not going to have any grandiosity or elevated mood. There will be none of the manic episodes, and it's chronic versus episodic. When we look at oppositional defiant disorder and intermittent explosive disorder, those disorders do not have the persistent mood symptoms between outbursts. You may have a co-occurring major depressive disorder, But that co-occurring disorder will be episodic versus chronic. And those are the primary differential diagnoses for the disruptive mood dysregulation disorder. And the text is very tightly written when it comes to age specifiers. And so before giving this diagnosis, it is highly recommended that you look at all of the different age criteria for this disorder. Okay, so specifiers for the bipolar disorders and depressive disorders. You have here, you will see that there are many, many different specifiers. I'm going to review a few of them just to kind of give you an idea of what they're talking about, and you may see here that you may end up doing some significant amount of writing for these because you may have someone who has major depressive disorder with moderate anxious distress, with rapid cycling, psychotic features, with peripartum onset in partial remission. So you can have all of these or any mixture of these as specifiers for either bipolar disorder or for depressive disorder. So when we look at, we have the familiar ones like the severity as well as those with or without psychotic features. There here is a clarification about the definition of rapid cycling, and that is that it's 4 episodes in the past 12 months. And while that was in the text in the DSM-4, it was not put up front in the diagnostic part. So they found that people were being diagnosed or being given a rapid cycling type bipolar disorder when in reality it did not meet criteria for rapid cycling. And also those individuals tended to have symptoms of other disorders such as personality disorders or anxiety disorders that better accounted for those symptoms. So the rapid cycling simply means 4 episodes in the past 12 months. And they also modified the postpartum onset to peripartum onset, as research showed that about 50% of individuals with postpartum onset actually had symptoms beginning during pregnancy. And they did find there have been some studies that show that women who received treatment during their last trimester, that there was actually better prognosis for the children as they grew up. There's some research articles that are cited in the DSM and that are also available on the APA website regarding this. So I'm going to review the new specifiers on the next slide. And just again with the ICD-9 and the ICD-10, you will be able to code for a single or multiple episodes, but you will need to write out the additional specifiers. So when we look at the new specifiers, one of the ones that came up that is present in a significant number of situations is with anxious distress. And this is for individuals that have 2 or more of the following. So they have found that we've known for a while that there is an overlap between depressive disorders and bipolar disorders and anxiety. So this specifier simply allows for that relationship to be acknowledged without a separate diagnosis being given. And so they also found in research studies that individuals who met criteria for the anxious distress specifier are at a higher risk for suicide, and their treatment outcomes were much more guarded. So they have to have at least 2 or more of feeling keyed up or tense, restless, poor concentration because of worry, overwhelming fear, feeling that they might lose control of themselves. All of those 2 or more, if they are present during the majority of the mood episode, would qualify for an anxious distress specifier. And you can also then note if that is mild, moderate, or severe depending upon the number of symptoms that are present. The atypical features specifier is used to separate it from the more classically agitated endogenous presentations of depression that were the norm when depression was rarely diagnosed in outpatient and almost never in adolescents or young adults. So that is the quote from the DSM-5. They do indicate that the mood reactivity that comes with atypical features is in that it's specific to a brightening of the depressed mood in response to desired or positive events. As for the sensitivity to rejection, the DSM-5 indicates that the hypersensitivity is not restricted to the presence of mood episodes, but worsens during those times. So while there is, when we look at the mood reactivity, there is not a whole lot of additional information that is given, and as there are multiple diagnoses that have mood reactivity, it can be a little bit more difficult. But when you look at the response to positive events along with the other symptoms of hypersomnia, long patterns of interpersonal rejection sensitivity, the leaden paralysis, and weight gain, that would qualify for with a typical feature specifier. And then the final point of that is that criteria for melancholic features or catatonia are not met. And the melancholic features are what we would typically see in someone who has really severe depression that has difficulty demonstrating any mood reactivity, has difficulty engaging with the outside world, severe difficulties in maintaining activities of daily living, and so that criteria cannot be met with the atypical features. So again, here is the criteria for the melancholic features, and it really heightens the focus on the anhedonia and the lack of reactivity. And in addition to that, you have profound despondency, moroseness, or empty mood. Depression is more severe in the morning. You have terminal insomnia, anorexia or weight loss, and excessive or inappropriate guilt. Now, this can be difficult as some of these are also hallmark characteristics of depression, and so it is left up to the diagnostician to determine if these symptoms necessitate the giving of an additional specifier. It does indicate that the individual with melancholic features almost always has significant psychomotor changes that are observable to others. So it will not, in general, be based solely on self-report. I included a brief vignette here. There's no correct answer to this, but just an idea to get you thinking about different pieces of information. So we have a mother who brings her 9-year-old son into you for services. He has been having trouble at school for ages, and this has led him to being placed in alternative school settings. She reports that he has these episodes and that they have been occurring since he was about 3 years old. She is unsure of what to do as these episodes seem to be out of his control and unprovoked. So the idea is, what additional pieces of information do you need to identify or to make a diagnosis? Because what you have here could range anywhere from a V code to bipolar disorder to PTSD to oppositional defiant disorder. So some of you may even need more information to even narrow it down to a chapter. so some of the pieces that you may want to look for are, what do these rages look like? What does he do specifically? Do these episodes happen exclusively in the school setting? What is his mood like in between episodes? Are there alterations in his sleeping and eating patterns? Does this happen only with authority figures, or does he have these rages with peers and family? What is his explanation for these behaviors? Did something traumatic happen at the age of 3? The reason why I included this vignette was just a reminder of how easy it is to jump to conclusions about behavior based upon our experiences, and that's important to consider all options before diagnosing, as diagnosing directs treatment. For example, I have worked extensively with individuals who have trauma, and so as soon as I hear 3 years old, my first thought is PTSD. And so it's just a good reminder that whatever we become familiar with, it tends to be what we see more frequently. And so just to make sure that we are addressing all of the possibilities and getting all the different pieces of information to make a more accurate diagnosis. And that is the end of Module 3. So please complete the post-test, and then you'll be able to start the next module. Thank you.